Hello, everyone. Welcome to another webinar from the Steps Forward Innovation Academy. Today, we'll be discussing topics covered in our Value of Feeling Valued playbook, which you will find linked in your resources widget and also online at stepsforward.org. Over the next 45 minutes, we will explore practical steps organizations can take to support individual physicians and make them feel valued. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA.
Hi, everyone. Thank you so much for joining us today. So my name is Jin. I am a general internist at Northwestern Medicine in Chicago, and I'm also a senior physician advisor in professional satisfaction and practice sustainability here at the AMA. And as Alex said, today, the topic of our webinar is how organizations can support their individual physicians at a level beyond the Muffin. This is based on the playbook, as Alec mentioned, that was authored by myself, Dr. Fogg, and our colleague, Dr. Hopkins here at the AMA. And Dr. Fogg and I are going to present the key strategies that are outlined in the playbook today. Dr. Fogg, I'll let you introduce yourself real quick.
Right. Good afternoon or morning or whatever it is for everybody. Jane Fogg, trained in internal medicine and practiced primary care and spent about 30 years in physician leadership in a variety of health settings, community health center, academic medical center, independent group, national group, employed. So have taken all of that and happily been part of this team for the last year, working with Jill and colleagues on this important work.
Yeah, perfect. Okay, so let's go ahead and dive in. Our learning objectives for today are number one, to recognize the importance of valuing individual physicians and how it is a key mitigator of physician burnout. Number two, describe the business case for valuing individual physicians. And number three, identify concrete strategies for organizations to value their physicians by supporting schedule autonomy, time off, professional development, personal resilience, and care during trauma and adverse events. Okay, so the first question we kind of want to ask is, why does feeling valued matter? Why do we care? Aside from it being the humane thing to do, there is also a financial benefit, a business case for investing in your people. And this idea of feeling valued kind of came about during the COVID pandemic. As you know, we were seeing record rates of burnout and turnover during that time, and organizations, including the AMA, really started looking at the data around this and asking questions via survey to clinicians around the country. One of the questions that was asked was, do you feel valued by your organization? And the responses came out, it was kind of surprising how strongly this specific response was linked to burnout rates. So among individuals who did feel valued by their organizations, there was only a 37% rate of burnout versus those who did not feel valued by their organization. There was a 69% rate of burnout. So this was published back in JAMA Health Forum in 2022 by Dr. Mark Linzer, myself, and colleagues. And we were really impressed to find this rate of difference. And these are absolute numbers, not relative numbers. So that's a 32% absolute difference in percent of burnout, which was very significant. So that kind of led to, the next question, which is, what does it mean to feel valued? How can organizations help their clinicians to feel valued? And so follow-up surveys were done on this and kind of yielded 6 key themes. So those were, number one, physical safety. Again, this is during the era of COVID and PPE. Number 2, compensation. Number 3, transparent and frequent communication. Number 4, effective teamwork. Number 5, empathetic and respectful leaders. And then finally, organizational support for individual clinician well-being. And this 6th bucket is the focus of the playbook, as well as our webinar today, because it is oftentimes the most nebulous for leaders to address and often the most challenging. And not only is it the most challenging, but it's arguably the most important bucket of them all, right? I think many leaders know the importance of teamwork and leadership skills and communication, et cetera. But where they kind of struggle is how do you actually support the individual at a level that is meaningful for them and in a way that avoids what we call muffin rage. Right? So this was an article that was published an op-ed in the LA Times, I think also in 2022. Everything was kind of during COVID when this all came about. By Dr. Gillian Horton, who is a physician based in Toronto, Canada. And she wrote about how her institution was having a physician appreciation day. And she was in the throes of burnout and kind of walking by a table with muffins and coffee and whatnot. And instead of feeling appreciated in that moment, she was overcome with rage. So she writes in this article, I was angry because I didn't need a muffin. I needed years worth of good sleep. I needed time to see my family a mere 1,000 miles away. I needed a vacation. I was so burned out and depressed, I should have been seeing a psychiatrist. I was deep, deep inside a black hole, and instead of a rope and a flashlight, someone had offered me a muffin. And then she goes on to say, muffin rage is what we feel when there is a vast chasm between our actual needs and what another person or institution thinks we need. So that's kind of the question we sought to answer in this playbook. How do we help individual physicians feel valued in a way that avoids muffin rage? And we came up with these 5 key strategies, and they are: number 1, support schedule flexibility and autonomy; number 2, support time off; number 3, support professional development; number 4, support individual resilience and self-care; and number 5, support care during and after trauma. So we will go through each of these briefly, but again, I encourage you to check out the full playbook, which is linked in your resources. But before I get to those, I'm going to let Dr. Fogg briefly describe the business case a little bit more.
So at the outset of this work, what's often on our minds is how are we going to have the time or the resources to invest in feeling valued, to invest in reducing burnout? Part of what we like to offer are some calculators to help you make that argument, whether it's your small private practice or you're in a larger health system. This calculator, available on our website, is an easy way to plug in numbers for your organization and look at your current level of burnout, your turnover rate, and estimate the total cost that burnout or lack of feeling valued will have on your organization. Because what we frequently find is we talk very much about the additional investments, the additional expenses it will take to improve the workplace without thinking about the other outcome, which is the reduction in turnover of physicians and APPs, the reduction in folks that reduce their work effort. So hopefully this is helpful to you in to translate this to a CFO when you want to talk about the steps we're going to take. So I'll go to the next one because I think I'm always most interested in the pragmatic. What can we actually do? And so scheduling is very pragmatic. Scheduling, whether it is your daily or weekly template or it is your shift work that you do, schedules have a great influence over our sense of wellness and feeling valued. Certainly, scheduling is very important to protect work pace, the flow of the day, reduce bottlenecks. It's what helps inform our work-life balance. But scheduling is also about patient access, about the ability to see your own patients, to have continuity in your practice or feel accessible to your patients and needs. And lastly, I think scheduling really represents how we work together as clinicians, how physicians, APPs, and we all work together to make sure we're adequately providing for the group of patients that we take care of. So it has a lot of impact. But there are a lot of forces out there that make it quite challenging. Put it right out in front. Productivity is a pressure that we often feel because of falling revenues across the healthcare landscape. And as we're being pushed to have our schedules filled, be productive, that can squeeze out time for our patients, for continuity, and that puts strains on us. So it feels like a real lever that we need to take a lot of attention to in order to promote feeling valued. So how would you do it? We offered a variety of ideas, but the principal one is that this is really a difficult problem, scheduling, and partnership from the clinical leads and the operational leads is most important. Partnering on designing the templates, on figuring out how to have equity across your practice, on figuring out how to make sure you can maintain continuity. Scheduling and thinking about how to make it not impossible if your child is suddenly ill, or as my child once did, dislocated an arm and I had to run out the door to take care of him. How do we quickly block my schedule without creating onerous steps? So there's a lot of ideas in here, how you can think about partnering. And the most important thing is have that physician oversight and have that operational oversight and figure out what will work best for you at your organization, but definitely have that clinician voice in scheduling in order to make sure everyone feels valued, but they also take care of the practice. So I'll hand it back to you, Jill.
Okay, thank you. So the second strategy that we talked about was supporting time off, or PTO. And this topic we have discussed before in various forums within Steps Forward, where we do have a toolkit about how to reduce barriers to taking time off. We also recorded a webinar as well as a podcast on this topic, which is, again, something that is very important, but also a challenge. We don't have time to go through all of the specific practical solutions here, but I do want to note some key points, which is, again, this is something that is directly linked to burnout. And again, it's always made sense as something that we know. If you think, physicians who don't take vacation will get burnt out, it makes sense on a logical level, but we also do have data to support that. And this study was published last year in JAMA Network Open, and we're looking specifically at vacation and burnout, and found that the one problem was that over 70% of physicians worked while they were on vacation. So even when they were off, they were not really off. And those who did work while on vacation more than 30 minutes a day, so that's still on patient care things and checking their EHR inboxes and whatnot, did have a higher risk of burnout than those who did not. And then on the flip side, those who took more vacation, more than 3 weeks of vacation, had a lower risk of burnout than those who did not. So we know that taking vacation is linked to burnout, and we also know it's in fact linked to turnover and intent to leave as well. So we, in this toolkit and playbook, kind of wanted to really start off by defining what PTO actually is, and broke it down into 3 components. The first one is that when you are off or on PTO, patient care and EHR responsibilities should be fully covered. The second is that the lead-in and catch-up time should be planned. And the third is that there's no negative impact on compensation, or perhaps a better way to say that is that the PTO time should be built into the compensation model. And there, again, in terms of how to accomplish these things, there's no one size fits all. Much like the scheduling, it really is going to be a team effort, and each work unit will have their own needs and solutions. But the idea is that these things should be the goals, and in discussing how to create lead-in and catch-up time and what the coverage model is and how the compensation model will work, this should be something that is transparently shared, and something that physician leads as well as optional leads work together to create. And aside from those 3 components, another kind of huge barrier is the culture, right? And in medicine, we physicians and other clinicians are just not good at taking time off. So that's another thing we kind of aim to try to start to fix in this playbook. And that ways to do that are that ensuring leaders are taking time off for themselves. So when the leaders are off, they are modeling not working while off, not sending or responding to emails, incorporating respect for time off into professional etiquette. Again, that goes back to the communications. Don't be emailing your colleagues when you know they are off. And, even if you put a footnote saying, don't feel the need to respond while they're off, they will still likely respond. So going the next step and just not sending that email at all, or scheduling it for later. Don't praise working while off, making PTO policies transparent and easily accessible. Again, that goes back to just the communication piece of it. And if nobody knows what the PTO policy is, if the physicians don't understand how taking a week off will affect their compensation, they might just be too scared to take any time off at all. So just making it more understandable and accessible. Proactively blocking off PTO time into the template. So just as holidays are blocked off into most ambulatory templates, blocking off PTO, a year or 2 years in advance. If you have 4 weeks off, just putting those holds on the schedule. Many physicians know which weeks they're going to be taking off, for example, for the kids' spring break or for Thanksgiving or whatnot. And those can be changed or removed later if necessary, but it's much easier to reschedule patients from 1 week to another, as opposed to finding time to add each of those patients back in later when there is not already that time blocked off. Engaging individual physicians and working with leaders for feedback and brainstorming, and then finally celebrating time away. Again, this is kind of low-hanging fruit as well, perhaps at the next team meeting, just asking people to share what they did while they were off, or if they were at a CME conference, asking them to share some pearls that they learned. Again, just making that part of the culture that it's time off is something to be expected and celebrated. All right, professional development, back to you, Jane.
So professional development, I think I want to be first level set that this applies to everyone, whether you're in a small practice that's just a few of us or a very large system. We work in a profession that has continuously developed us in our training, and then at a certain point you land in your role as an attending, as a full doctor, and it should not stop there. Feeling valued means the people around you, your supervisor in particularly, but your colleagues know who you are and what excites you and what makes you passionate beyond simply being a doctor. And so there's a lot of, I think, focus sometimes on thinking, well, it's, we don't need that much help in professional development. We finally made it. But what I want to talk about are things that will allow your team to better know you and value parts of you that you might not have otherwise shared. So professional development to me, as someone who's done a lot of physician leadership in the past, first and foremost, it's not the same thing for everybody. Some people aspire to be the best clinician possible, and that is absolutely the major focus of many development activities. And as you do that, you may find that they've developed some skills in a particular area that you'd like them to share with others, that you want them to, perhaps they want to get into teaching and they haven't thought about that. There are places in entrepreneurship, in research that also are appealing to those who really want to focus on clinical medicine. There's also many of us who want to see things work better. And so whether or not you aspire to being a leader or you just want to be part of a process improvement project, this is another area where you can encourage physicians to explore those areas, to get on committees, to start doing some work that will help them see how things work together and feel like they're contributing. And importantly, it doesn't end at the walls of our organization or our office. Many physicians I've worked with over the years have been highly engaged in their communities, sitting on boards of health, working in advocacy around public health issues. Many have been highly engaged in our professional community bodies, professional agencies working to improve the care delivery across a multitude of specialties. So professional development is really saying, what is it that you aspire to? What excites you? So how would you actually do that? And I think, again, I've worked in organizations that are small and large, and some have very formal annual review processes and some have none. I highly recommend, even if you're in the none category, you think about having that regular, at least annual conversation with everyone in your practice, asking them just an open-ended question. Where do you see yourself in 3 to 5 years? Outside of taking care of patients, what excites you? What teaching, becoming a mentor, doing research, and so on. If you're somebody who always has an idea in our group meeting, maybe you want to be more involved in improving areas of our practice. What things would you like to contribute to improving in our practice? And are there other aspects of health delivery you might want to learn about? Can I introduce you to somebody who can teach you more about healthcare finance or teach you more about leadership, process improvement, value-based care, population health? The point is to be very open-ended because you're encouraging them to tell you what matters most to them without the fear that they're going to say, well, I'm really planning on cutting down and being part-time. You need to open the door and say, well, what are the ways in which we can nurture your passions and interests so that you want to stay with this practice and so that you feel good and you feel valued?
Okay, so
Advance
next
the slide slowly.
Next strategy that we talk about is supporting individual resilience and self-care. And we all know that physicians are not lacking in individual resilience, and as a group, physicians are more resilient than the general population. So it's burnout is not a deficit in that, and this should not be the primary focus of institutional or organizational initiatives. Should not focus the majority of their efforts on this. However, it's also something that cannot be ignored. And even when we have the structural solutions in place, we still need to be supporting our individual physicians in their self-care and individual resilience. So we do offer some ideas on how to foster this in the playbook. We have a table that highlights individual actions as well as organizational actions to support individual resilience and self-care. And some of those, off the top of my mind, since the slide is not advancing, were to set boundaries, for example, to prioritize your to-do list, to limit distractions, and limit commitments. So it's really just about, the whole idea that multitasking is a myth, and we really need to be setting boundaries in limiting our commitments and limiting the things that we are saying yes to. And we can do that as individuals, but also organizations can help support us in doing that by, for example, limiting the communications that go out to us in our emails, limiting the surveys that they're asking their physicians to take, and scheduling meetings for 45 minutes instead of the full hour, giving, in terms of back to the scheduling, a full hour for lunch, and some of the things that can really promote self-care, providing enough, break times, or providing space for taking breaks and promoting collegiality. So those are some of the things. Again, there's a table in our playbook that offers some specific strategies that can help with that.
So the additional aspect that we wanted to talk about is providing thoughtful and proactive support during and after trauma. And when we think about trauma that occurs to us, it can be both on an individual level, but it can also be on a group level. Individual traumas can be everything from going through a malpractice suit to witnessing a significant tragedy in your practice, to experiencing violence in your practice, to having which many of us have experienced. And collective trauma is also important to think about. This is where something impacts the group and can cause a loss of cohesion, a loss of community. And you think obvious examples, things like the pandemic stressed our entire group quite a bit. Mass shootings stress many of those who take care or work in settings where they take care of people who've experienced that. We're all having some challenges experiencing the politicization of healthcare. And so there are things that add to what I'd call collective trauma. So if you go to the next slide, on responding to individual trauma, one thing that's really important is to think about what kinds of programs you can set up, and hopefully before an individual trauma happens. But we're going to share a variety of links to toolkits which expand upon these peer support programs, but really using an evidence-based tested framework like the stress first aid framework. A lot of these frameworks are just here to help us say, what's step 1, 2, 3, 4, 5? Who do I need to include? How do we communicate? How do we think about sort of calming this current situation? And then what are the next steps after that? So these are really great playbooks to look at. Additionally, offering confidential mental health services for physicians is really important. And again, we want to be clear that burnout is not a sign of mental illness, but there is a lot of overlap that happens when we are severely distressed by the way in which we're practicing and what we're witnessing in our practices. And at the very worst, suicide is higher in female physicians than in the female population. Male physicians, it's now the same as the male population, but it has been higher in our population and touches us each in a very deep and profound way. So suicide prevention plans, as well as having a response team, being able to think proactively, again, step 1, 2, 3, 4, 5, what am I going to do if I'm the chief wellness officer, the medical director, or just the colleague of somebody who recently committed suicide. So the last one is also the credentialing process. Lorna Breen Foundation and many others have been advocating to remove language about mental health history in our credentialing process to make it safer for us to seek care when we need to seek it. So if you go to the next slide, which I still can't see, Alec, but I think we have the playbooks here for peer support, for preventing suicide, for after a physician's suicide. And talking to one chief wellness officer at an organization, she said that was the most helpful playbook I've read this year because it helped walk me through a very difficult time and gave me some structure and some support. And with collective trauma, I think these last two playbooks on the final slide are also really, really valuable and worth reading. So we wanted to add those as resources. But main message, think now about what structures you want to have in place for when and if these things may happen. And if something has happened, maybe take a look at these and see if what your steps were, did they align with what others are doing. We have a lot of great success stories in our podcast and such as well. So lots of other resources to hear how other people are doing it.
We did want to leave plenty of time for questions. So please feel free to put something into the question box if you have any at this time. Okay, so let me just take a moment to look at what is coming through. Okay, so Jane, you can probably see these as well in the Q&A box. One of the questions was, what intervention have you made that has had the most impact? What's a good first step? I guess kind of a low-hanging fruit type of intervention. Do you have any thoughts that first come to your mind?
Yeah, I mean, I think one thing that's really important is measuring, getting input, assessing. So hopefully first step is that we are demonstrating that we care and we want to do something by asking, whether you're having focus groups, you're having listening campaigns, leadership coming and really talking to folks about what's on their mind, or doing survey measurements like the org biopsy or other measurement tools. So I think measuring in itself is actually a proactive step. I help lead the organizational assessment arm of our work, and I think this question comes up every day, and it's really hard to say there's one thing you do and that's the best. I think always, as a baseline, you want to have the efficiency, the well-working of your practice embedded in your daily clinical operations. It shouldn't be something you talk about every so often. It should just be part and parcel of every day. How are we doing on scheduling? How are we doing on the phones? How is documentation going? Are there any problems with referrals not going through and so on? So I think that's like a baseline state. But I would say the second thing that you might want to think about being impactful is really addressing your leadership presence and the skill set you bring, the leadership philosophy you bring, how you develop and give feedback to leaders so that they can do many of the things we just listed here. So I think leadership has a really important impact. And again, I mean that at every size of the practice.
Yeah, I think I agree with that. And then in the listening sessions in particular, or just it doesn't even have to be a formal listening session, just listening to an individual when an individual comes to you with a specific ask, instead of automatically saying, no, that's the policy, we can't do that. Kind of coming to it with an open mind and saying, well, how can we make this happen? And just really making that physician feel like they are heard or that they matter and they're not just another replaceable person that's generating our views. So whether it's going back to the scheduling thing, if they want an extra half day of telehealth to have more flexibility with their kids or something, just really understanding the story, the personal story behind it, and whether in the end that's possible or not, that listening component is what I find personally goes a long way. Okay, let's see. I think this is an interesting a question I don't have a great answer to. So, we talked about the Muffin rage at the beginning, and this question about what is a meaningful way to acknowledge events like a doctor's day, and is if that is, if we can make that into something more meaningful.
I think it's a great question, and I worked in an organization that did it in a variety of ways. And I would say, there's never the perfect way to do it. But most importantly, what I've often heard was personalized. You sent me something, but it wasn't a personalized acknowledgement of my contributions. And obviously, in a large organization with hundreds of doctors, you can't necessarily personalize each and every one, but you can work through your management structure to try to provide some of that. So yes, we gave out booklet, we gave out pens and pins and things like that. But most important thing was every single local leader spending the time to round with all of their folks, whether they're in an ambulatory or in a hospital situation, to say, I just want to say how much I appreciate the work and commitment you put forward, the way you take care of our patients. I know we haven't been able to support you in every way that we need to, but I want you to know we're working on that, and we really, really value you. I've had some folks tell me that when people retire after 30, 40 years of practice, it's really interesting how differently we handle that. And I think the most beautiful thing is a real personalized acknowledgement of those decades of service. And I used to take the time to write every physician on their major anniversary in my service line, just to say, I see you. You may not see me every day. It was a big geography, but I really value you, and I so appreciate what you do. So try to personalize wherever you can, and then just try to be humble and honest, and acknowledge all that we want to do that we haven't been able to do yet.
Another question that came through was, are there pre-built surveys to send out to providers that you would recommend for doctors to feel more valued, or to help physicians feel more valued? I don't know any specific. I don't think there has to be a specific survey, actually, is my answer. Whether it's Press Ganey or the Mini Z, or it can be any survey that's used. But I think the key point is taking those responses and actually acting on them. And it's so that physicians filling them out, they're knowing it's not just going into a void, but actually taking those comments and what can be improved and responding, and having that closed loop communication about the problems. And even if there is no solution, at least knowing that it's something that the leaders recognize and are working on, I think is the most crucial part of the feeling valued piece.
I agree, Jill, and I'll just add a piece, because we do actually have an assessment service that is part of our mission work at the AMA, that people are not charged for it. We do it for organizations who would like to survey in large numbers physicians and advanced practice providers on the current wellness. And what we try to add to it, which I think has been really valuable, is the Mini Z is a core part of it, which is asking some basic questions about work environment and reported burnout, but then trying to drive a little further into what's happening underneath that. And so we have key performance indicators, one of which is your sense of feeling valued, your intention to leave, your reported burnout, your job stress, your job satisfaction. But we also ask about things about the usability of your EHR, the amount of time you're spending on your electronic health record. We ask about teaming and delegation. We have leadership questions. And so we have a whole compendium of questions, but what we try to do is hone it into something that gives you more actionable steps. And so I think that maybe that's one added pearl is, yes, first measure and get started, but secondly, think beyond knowing how much feeling valued there is there. What else do I want to know? Do I want to know about system efficiency? Do I want to know about culture? Do I want to know about leadership? You can't ask every question, or it'll be way too long of a survey. You can rotate things around. You can, decide to focus on leadership for a while and see how people feel about their leaders, and just start there. That's a really good basic one. But I think that that's really, really important, that you think about measuring it and sharing it back to everyone who is surveyed.
Yeah, absolutely. And that's actually a kind of link to this next question that came through, which is, what is a good working definition of well-being? Could you expand on those KPIs, Jane, in the organizational biopsy, and kind of how do we define burnout versus well-being versus satisfaction?
Yeah, it's, I think I appreciate, trying to have a standard definition. I've had the pleasure of being a physician leader for a long time. And so I think I've learned beyond the definition, there's also kind of, it's not as precise as that. I think well-being to me, what I've seen in most of my career for physicians, is when it's not about we're working too hard. It's about I feel that I'm working in an effective and impactful way. I feel like I have some mastery over my clinical skills, that I am a good caregiver, that I can help and advocate for my patients. I think most of us who've gone into medicine, we're going to work hard. It's not that, it's that ability to feel like I'm effective. And then when there are obstacles in the healthcare system, somebody is mindfully trying to remove those obstacles, those administrative burdens, so that I can really focus on being a good doctor or being a good APP. And so that to me is well-being. As I hesitate to say it's about working a certain amount of time, because I'm sure all of you have had colleagues who work, extraordinary long hours, and those who work more limited hours. We all are different. It's just about being impactful and feeling supported in your environment. Our KPIs try to hit on many of those themes. But again, those are key performance indicators that we use so people can compare to benchmarks. Like we know in the past year, reported sense of burnout had peaked around 61% in 2021, measuring off the pandemic. We've now gotten down to below 50%. It's been eking down somewhere around 44%. So we're using these KPIs to also understand what's happening nationally and to try to gain some insights into what are the best ways to support well-being and reduce burnout. I'm actually curious, Jill, I see the question here about how many organizations have a chief wellness officer, which I thought, is a great question, number one. My last organization did not. And so I was the chair of internal medicine. So I sort of, as part of what I did alongside people in professional development, it's a really lovely thing to see this role growing and expanding across the country. I think well, no one person can solve everything, a chief wellness officer, but it is emblematic of the commitment. And a chief wellness officer influences all those that are running the various departments, all those that are running operations. They're there to sort of tie it together to how is this creating a positive working environment. I would love to know the answer to your question of how many organizations do. I'd say I see it very commonly now, but I don't actually have a hard number for you. That's a great question. And we have a toolkit on that, which if you're thinking about it, really good toolkits on the role, the scope, and so on.
Yes, correct. And I think, yes, I wish I had a specific answer, and I can look and we can find that out probably, but I think it's definitely in the past 5 years, I would say, really shifted towards something that was before an exception to now the norm. And yes, we have two toolkits. One is called Creating a CW Position, and the other one is the CWO Roadmap, about how to lay out the work that the CWO will do. And now, as the role is growing, we are looking to expand that into not only a roadmap for the CWO, but now many CWOs have different well-being directors. Now there's a whole network that kind of they will oversee. So kind of even expanding beyond that is kind of the next step. It's been exciting to see that grow as a commitment. Question about peer support. Jane, do you have any experience with effective peer support groups and how to establish those?
And we've gotten this question a lot at the AMA, and I think actually the struggle in answering is that I've seen a variety of different approaches, and I don't think I could say one is the best way. I do think that in peer support, some of the common themes that are helpful is certainly training those that are doing the support and helping provide them with tools that they can use when they are working with their colleagues on peer support. The other is really having people who will be using the system and who will be providing in the system help design the system. So not designing it in a vacuum as part, as a chief wellness officer say, but really going out and saying what would be helpful, because we are all extraordinarily busy and it is hard to make time for these, even for peer support. And there's also a hesitancy for any of us to say we need help. And so you want to think through what's the best way to do that. Certainly one key thing I have seen is that the reason why peer support or mentorship has been really helpful is it is sometimes a hard power dynamic to go to your immediate supervisor when you need help, and you may be more comfortable going to a peer as opposed to your local medical director, because I think might feel like it spills over into an annual review process. But I think we have some good, we can actually maybe pull together some of the podcasts where people have described their program and what worked well for them, because I think that that would probably be the most helpful way to illustrate different ways to do it.
Yeah, and I think that you, like you mentioned, there's different, there's peer support kind of specifically for adverse events or lawsuits or some things, and then there's kind of peer mentorship in general for guidance and mentorship and professional development, and then there's coaching, like either individual or group coaching, all of which we do have Steps Forward toolkits on, but also our podcasts and or toolkits, and all of which can be helpful in their own ways. So it doesn't have to be, one, again, there's not one size fits all. And coaching, especially group coaching, is something where you can kind of impact a lot of people at once, and has been shown, there's been that strong evidence to support that really helps with burnout, imposter syndrome, and things like that. So I think that's another kind of very good intervention in addition to peer support.
And just wanted to add one of the, I see Lisa in the audience here. Thank you for contributing this. The CHARM CWO network is a network of CWOs, and they are, you can look them up online. They have some great tools, and they're working on a white paper with some good descriptors. And so really excited to see that, and happy to have these additional resources. So that's a great resource. I think there's one question. I never hesitate. I like a good PCP. I like a hard question. And one of the questions that was posited here before is really about sort of a cultural theme of what should we hold on to, and when should we let go of that commitment to medicine as a calling that requires dedication and sacrifice. And I know that has elevated, I don't know, in many different forums recently about that. Some people describe it as a generational divide. I think it may not be so much generational as what, how we're feeling at the moment. Like, should we have to sacrifice to be good doctors? Is that what you have to do? And as I said earlier, I mean, my position on this is everyone I've worked with has always been a really hard worker and really dedicated to patient care. I think the sacrifice is when you're trying to make up for problems in the system that are impeding patient care, that are making it hard to get things done. And that to me does not feel right. We should be facilitating clinical environments where all of us don't have to sacrifice. We can be dedicated and work long hours, but we don't have to sacrifice to get things done. So that's kind of how I think of it. I don't know, Jill, if you've thought about this.
I have, because I have heard a lot about the generational, before, this kind of different culture, for better or for worse, of the younger physicians who are now being a little bit more clear about boundaries, and when they're off, and even with residency training, the work hours, and when they're done, they go home instead of staying on for learning, and as as more of a calling type of situation. And I think that there perhaps is a little bit more of a cultural shift, which is not a bad thing, but also there are more, objectively more burdens, administrative and EHR work-related burdens than before. So I think that you want to be able to get stuff done, like you said, Jane. You want to do something for patient care and have a system in place where that reliably gets done. And we also just want to remove the extraneous burdens, because now more than ever, there are just so many extra steps for anything that through the EHR, through technology. There's so much that we're putting in our own orders. We're calling patients ourselves instead of having things that before, when physicians had perhaps more independence and less boundaries, is they didn't have to deal with all that administrative burden. Also, there was probably less regulatory burden back then. So I think there is just both things. The culture is changing, but also the nature of the work has changed. So that's kind of what we're up against right now. I think we're over time. So thank you everybody for joining in today. Hopefully that was helpful. Feel free to contact us with any additional questions. Please check out the resources.